Previously, we had a cordial engagement with ministry, where if there's a pronouncement of recruitment, I think associations will be called. You sit to speak to the numbers of the doctors to be employed, to speak to the criteria of how doctors should be employed, and we would engage the unemployed doctors to decide on how they would want to be employed. So fast forward to the past recruitment, we had a meeting. We spoke to the numbers and promotions, and we had the criteria. I think the criteria was put in place, and it was to not allow new applications. I think this was to reduce the pool of applicants, to give a better chance of people that have been in the system for some time to be employed. But what we saw, Prof, was when we went to the list of doctors that were employed, and we compared to the database that we got from PSMD, we had over 220 doctors who were not part of the applicants. And we wrote to ministry to just seek clarity on what happened. How did ministry get these names that were not part of applicants when there was no call for applications?
Hello, welcome to our podcast. My name is Professor Wilbroad. This is a Think Talk podcast where we address issues that are pertinent, and by the way, we are here because of you. We wanted to bring these things into the comfort of your home, and hopefully you are enjoying a number of series that we have run before. And this week we are continuing an important topic of the doctors that are volunteering in the health system. And by the 2nd of June, the RDAZ, which is the association tasked with looking after the welfare of these doctors, asked that these volunteer doctors take a break until government or stakeholders respond. But for the doctors, it seems that the health sector was expecting them to go there for free, shouldering the whole burden of primary health care on behalf of stakeholders, the patients, the government, and everyone else who uses the health systems. And the RDAZ said no to that. And the discussion is ongoing, government is involved, and many other stakeholders are talking. And we wanted to hear if RDAZ has got any solution to this matter. So join me, I am with Dr. Chibwe. Dr. Chibwe, welcome once again. I hope you rested a bit after we talked the first episode. I was very encouraged with your passion about this matter. So Dr. Chibwe, today I want us to focus on some of the things that we can do as RDAZ, as government, as stakeholders. How can we help you succeed? Are there solutions to this problem? Is going on strike the only solution, or stoppage work? Are there other things that you think government should do to address this? Other stakeholders, don't just focus on government.
I think this is not a movement that affects government alone. I think the most important team in this case is the public, the patients. But one thing, if I'm to draw attention, these patients to the fact that when you go to any facility that you wish to go to, because we are potential patients, would you want to be seen by a doctor who before coming for work in the morning, they were reminded of rent, and then they for some reason they're doing a side hustle job, they're selling shoes, so they're seeing you in the facilities with their phones on just hoping for a client to call them to say deliver shoes, or just to come through with their business. You don't want that. I was having a discussion with one of our friends in Botswana, and those for lack of better terms, they're well paid. And the rationale with what he said was, government wants undivided attention. They don't want medical personnel seeing patients working quickly so that they can escape to have another job, so they can sustain their families. They make sure everything comes in as a package, so that the one thing that you think about is when you knock off, you want some time off with your families, just to catch up. I think if we have this package in these doctors, remember when you go to these hospitals, there's a certain step, Prof, that public don't understand, and this is what they're terming internship. For as an association, we call it junior residence. So they are the first contact in the facilities. So you get to see these personnel, and most of these facilities, you have out of 10, you have only 2 on payroll. And meaning the rest of the doctors that see you, they are not, they are not supported financially. Meaning they would see you, with a divided attention, because at the end of the day, they have to have a certain time to look for money, so that tomorrow they show up for work, tomorrow they pay rent. I happen to be in the system, and I've worked with some of these colleagues. They would ask for permission because they want to go and order a few clothes to resell. They would want to escape and do yango and whatnot, and we don't need a system that has people working like that, want an undivided attention to these patients. And patients, that's what you deserve. You deserve to have doctors seeing you, knowing that when they go back home, they will rest on a financial backing that is being supported from the government. In terms of solutions, Prof, you've seen, I think, let's not sugarcoat anything. There is money. There is money. You have. I can speak of CDF. CDF is being increased, and you have all these pronouncements of establishing facilities in all these constituencies. But who's going to man these facilities? Why can't we have a certain section, as because the health financing isn't just about facilities. You have a certain section that's supposed to speak to human resource and career development. So why we have a certain portion of CDF to speak to the facilities? Why don't you have a section to speak to workforce? I think that's one of, yes. Look at the allocation as well. I think for some time we haven't had the up to standard, regional acceptable standard of health financing. From the 15% regional standard, I think we've dropped now to 10.6. Meaning our sector is underfunded from the start. Why can't we have efforts to prioritize funding, just for a year to have up to standard, so that a certain location speaks to the need assessment of the workforce that is needed in the country. I think this is one of the key issues. But another issue, I think, is monitoring of health financing. So, Prof, you are aware of the how now setting allowance of doctors has become a myth. In the past, I think we had the previous ministry. We had word that the money was sent to these facilities. Where some of our colleagues received money, and we had word on the ground that some of the facilities repurposed the funding, and you'd question why. Where are the monitoring mechanisms? Why would you repurpose something? Isn't that an audit query? You can't give such as a reason. And then you have, so this is to speak to the fact that these facilities were saying they were not funded, according to the need. But is it a doctor's job to fund these facilities? Where are the cushioning mechanisms, such as schemes, such as, for example, NIMA? Now we have NIMA buying CT scans to facilities that don't even need those, the scans. You go to Levy, there's a CT scan that's just seated, and they don't have where to put it. So if NIMA can prioritize financing in these facilities enough to cover their day-to-day running of facilities, there would be no need of repurposing the money that is supposed to go to doctors and act as a motivating mechanism, so that they can continue working and supporting the healthcare in the country.
All right. So for the doctors who are already in strike or they're on voluntarily, they have stopped volunteering. What outcome are you looking for? Like, what kind of settlement are you expecting, and what would tell you that you have reached where you wanted to go? What are some of the telltale signs that will tell you that now they can go back? What is it that you're looking for?
Well, the first thing is just proper engagement. I think we've been deliberate on our demands. We don't want these demands to be aired to to the public. I think these demands are supposed to be addressed to Ministry of Health, and we've been asking for proper engagement where we have our demands. But in a nutshell, we just want these doctors to be employed. As simple as that. If you look at the previous meeting that we were called in, it wasn't a two-party discussion. It was ministry coming to air out their position on the matter, and their position was we can't employ doctors now. We have 2,000 healthcare workers to be employed. But if you look at the need assessment right now, Prof, the previous recruitment, there was 11,000 healthcare workers to be employed, and only 400 positions were for doctors. If you look at now the 2,000, how many doctors are going to be recruited in this recruitment? Meaning 100, but this 100, Prof, can't even cover the deficit just at UTH alone. It can't.
How do you do that engagement as that RZZ to bring these people to the table?
Well, I think recently we saw a statement from ZME to speak to the same issue, and I think we're on course. The ZME agrees with the issues that we brought out as RDSZ, and in these discussions, first of all, it's a series of events, Prof. Yeah. We previously we had a cordial engagement with ministry, where if there's a pronouncement of recruitments, I think associations will be called. You sit to speak to the numbers of the doctors to be employed, to speak to the criteria of how doctors should be employed, and we would engage the unemployed doctors to decide on how they would want to be employed. So fast forward to the past recruitment, we had a meeting, we spoke to the numbers and promotions, and we had the criteria. I think the criteria was put in place, and it was to not allow new applications. I think this was to reduce the pool of applicants, to give a better chance of people that have been in the system for some time to be employed. But what we saw, Prof, was when we went to the list of doctors that were employed, and we compared to the database that we got from PSMD, we had over 220 doctors who were not part of the applicants. And we wrote to ministry to just seek clarity on what happened. How did ministry get these names that were not part of applicants when there was no call for applications? We never got feedback from that. The only feedback that we got was the minister spoke to the media as opposed to engaging the association. We reported the matter to ACC. ACC came out that were not part of the process. We went as far as submitting the issue to public protector, where we presented with evidence of the names that were on the list and the names that were not part of the applicants, and we questioned how those names found themselves on the list of people that got employed. In pushing this, we remembered even these doctors that were employed in a way that we didn't understand. They happened to be our members, Prof. We wouldn't want to push for aggressive measures, but what we wanted was to have a proper engagement so that we have the answers on what happened, and we have a way of not to appeal to the ministry for this not to ever happen again, as this it erodes the confidence that the doctors have in the system and the associations as well. And this is where the issue now came from. After that, there was just a bit of punchback where we would engage through a letter. We submitted it to the ministry, the Ministry of Health, for a CATE score, and that CATE score, we just wanted to have a sit down where we have our agendas in place, and we have the agenda of the government of the day, and we make sure all these align so that as we work as a team. But there's a little commitment, in this line. We don't have the impactful engagement from the other side. What we want, Prof, I think, is a bit of commitment In as much as these doctors wake up to offer free labor, we want commitments from our stakeholders.
Excellent. So I do hear what you are saying. So you are asking for, at least even when this thing is ongoing, you are willing to have a dialogue with the stakeholders, especially the Minister of Health, government officials, to hear you out. Is that correct, Doctor?
That's correct. We moved Prof from Sunday, response from ministry through media. Very unusual for ministry to have a briefing on a Sunday and call it routine. We moved from there to another post around 22 hours from the minister, then to Monday, where we had now superintendents threatening our doctors, calling them on their person's phones to come back to these facilities or risk being blacklisted. Phone calls to say, if you don't come back, you never come back, we won't sign your logbooks. These are threats to the following day, Tuesday, where we received a letter, and that letter was issuing threats to me as I may face disciplinary action with a potential charge of advocating for disruption of service by government employee. From these, Prof, I think after that we attended the meeting at 14 hours that was called by PS administration and donor coordination, Dr. George Sinyango, with directors, and that meeting wasn't a dialogue. It was even stated in the letter to say, so that we give you a position from the ministry side, and it was a meeting like that. After that, Prof, we had for the first time ministry releasing minutes of the meeting on their page, and a lot of proceedings were distorted. I think the summary was, I think the intent was, first of all, to make it seem RDZ didn't really prioritize employment that we've been calling for. We started talking about other issues, and part of it was to paint doctors self-entitled by the rest of the cadres, and that's not a way to go, because we're not politicians. For us, coming forward isn't a fight, isn't to undermine the ministry, is to call for attention. Hence, we do not expect, and we didn't expect, punch packs and being undermined and whatsoever threats and whatever is happening right now.
All right, so Doc, we have to leave it here, but I wanted to hold you in the next episode to think about what the private sector can also do to this crisis. So that's what I wanted to talk to you about. But just to summarize what you've told me today, and to the Zambian people as well, and to all the people listening, that you are interested as well in the welfare of the patients who are our central customers. And then you worry that the system is not supporting you and it's using like some kind of like cover to run a system which is not sustainable. And so you have brought that to the table. And what you are asking for, from my understanding of what you have said, is that you want engagement. You want a situation where you sit with government and the RDZ and other stakeholders and come to a consensus, not to undermine or threaten each other. Is that my position correct? Did I summarize that well?
Yes, that's a perfect summary, Prof. That's a very perfect summary.
Thank you so much, Dr. Chibwe, for coming. And to our viewers, please listen in to our next podcast, because I wanted to talk about the private sector. You know, some of the training is happening in the private sector, some of the practice. Is there a role that the private sector can come in and help some of the numbers we are seeing for the doctors? What is preventing that from happening? So please do join me next week. Thank you for watching.
Think Talk with Professor Wilbroad.